This episode contains graphic descriptions of real medical scenarios faced by real medical professionals. Listener discretion is advised. From Knowledgeable Provider, this is Critical Incident. Hey there, welcome back to Critical Incident from Knowledgeable Provider. I'm your host, Jody Marks. One thing that I do miss about working on the ambulance and in acute care as a nurse is getting the opportunity to really save someone's life. As in, there was something wrong with you that I fixed and you're still alive because of it. I don't know that there's really a more rewarding feeling or a more important thing that you can do in the medical field. And I think, at least I thought when I was initially getting into medicine as a paramedic student, that I would be doing that all the time. And I would assume that other people, whatever their entry into medicine is, whatever path they take, probably think the same thing. Maybe we just assume that people only use medical services when they're critically ill or injured. Maybe we just have a false impression from watching TV shows about emergency medicine and first responders and whatnot. But it turned out, at least in my experience, that those instances where you really get to do something super cool and high speed and literally save somebody's life in the moment are vanishingly rare. And I'm primarily talking about EMS here. In my experience, most of what you spend your time dealing with is just a bunch of bullshit. Sorry, Mom. You go around pretending like you're responding to emergency calls when really what you're dealing with are people who could have well driven themselves to the hospital or gone to see their primary care person or an urgent care or whatever. There was kind of a running joke when I worked on the ambulance about having to park on the street at somebody's house because the driveway was so full of cars, any of which could have transported them to the hospital. Have to weave your way through all of those vehicles to get to this person who's not really sick and then try to weave your way out with them to get back to the ambulance. It always kind of mystified me how people would wait, 30, 45 minutes for us to show up. And I'm going, in that time, you could have driven yourself to the hospital and you'd already be there. One thing that I found was very hard about being a medic was trying to maintain your sense of urgency and your critical skills, because that's just not what you do. You can coast through your days and pretty much be sure that you're not going to take care of anybody who's super sick today. And I definitely saw in myself and in some of my coworkers that you just sort of default back to, get in the truck, let's go to the hospital. And we don't always pick up on the things that we're actually supposed to be dealing with and looking for, because it gets really hard to maintain that level of proficiency and awareness when you're just functioning like an Uber or taxi all day. One thing that I always found really amusing was the way the dispatch system that we used to triage or prioritize patients was really good at funneling everybody into an emergent pathway. As in, okay, we've used this software now to decide that this is a level, whatever, I don't remember how the classification went, but this is an alpha level call that you're going to respond lights and siren to, and we're going to send the fire department and the ambulance and all these people because the software has determined that this is a true emergency. And they were almost never true emergencies, to the point where, again, this is just my impression, anecdotal experience. I got to where if they ever told me to go somewhere non-emergency, I'm like, okay, this is going to be the true emergency, because they're so not used to talking to people who are really sick that the really sick people actually fall outside the algorithm and get categorized as non-emergent. By the end of my time at the ambulance service, I would really only get freaked out if they told me to go somewhere non-emergency. I'm like, hell, this is going to be the real emergency for the day. But all that being said, once in a great while, you do get a chance to intervene and truly save someone's life. And I can think of a few examples from my career. I've already talked about the gentleman who coded on us, but had an ICD in place, so he kind of uncoded while we were screwing around trying to do what we were supposed to do. And so that was a situation where his heart had stopped, and then by the time we got to the hospital, he was awake and talking and doing well again. Something like that happened another time when I had a student with me. It was a call for chest pain, and the patient was just kind of sitting in the middle of the floor in the living room, and he looked okay, and we actually had him stand up and walk to the stretcher, and we're bebopping along, just doing our thing, and on the way to the hospital, suddenly he goes into PEA. Like, his rhythm on the monitor, I don't think changed. I think he just lost a pulse, became unresponsive. And so we started chest compressions real quick. We already had an IV, so we gave him a dose of epi, and boom, heart started right back. Was beating when we got to the hospital. One time I picked up a lady complaining of chest pain. She was a middle-aged kind of lady, actually really healthy looking type just to look at her. And we get there and she's up bouncing around, like almost hyper kind of. And of course, the first thing you think in that situation is, well, this person's obviously fine, right? Sick people don't bounce around the room like Tigger. And we're talking to her, getting the history, and she says, yeah, I've been using some nitroglycerin. And I want to say she had taken like 9 doses of nitroglycerin. It may have even been more than that. It was like substantially more than you would expect. She had had a crap ton of nitroglycerin over, I don't remember what period of time, but I remember being surprised that she still had a blood pressure, So we get her loaded up. We're on the way to the hospital. We're in the back of the truck. She's on the monitor. I've already called my report to the receiving facility. We're just business as usual. And all of a sudden she said something. I think she said something like, I'm going down. And looked at the monitor and her heart rate has sped up. She's in SVT now. So I'm cycling the blood pressure to get another set of vital signs. I'm trying to call the hospital and let them know that the situation has changed. And then boom, she codes. She goes into VFib. And in those situations when that happens, it's a little bit difficult for your brain to change gears. You're already in this mode of, okay, here's what's going on. This is what we got. Here's our status. This is what we're doing. And when everything suddenly changes like that, you just kind of have this moment of like, what? When you're trying to figure out what you're supposed to do next. Because it's not what we signed up for, right? It's not what we were dealing with just a second ago. I remember one time when I was a student, I was on a cardiac arrest call where we got a pulse back in the field. Or maybe I was a volunteer responder at the time, or maybe both. Anyway, I was in the back of a Helen Keller ambulance participating in a cardiac arrest, and we got a pulse back on somebody. And I'll never forget the medic, who was a very experienced, well-regarded medic, going, well, I don't know what to do now. This never happens. But anyway, back to my call. And in my memory, this actually happened like on Governor's Drive with inside of the hospital. So there's no way we're stopping the truck to code this lady like in the hospital parking lot, right? So I yell up front to my partner, tell him that she's coded. One of us must have called the receiving facility back to let him know that that had happened. I don't remember if I did that or he did that. When you're by yourself in the back of the truck without any help and you have 10 things you need to do all at once like that, you can't do everything all at once. You can only do one thing at a time. So you have to kind of prioritize. Whereas what we want to do is start CPR and get an advanced airway and manage the arrhythmia, get more IV access, whatever. Well, you can only do one of those things when you're by yourself. So I decided that she was on the monitor. She's clearly in VFib. I'm just going to defibrillate her. So I put the patches on, charge it up, shock her, and boom, she's right back. Pulse restored. She comes back around. By the time we get into the ER room, she's awake, talking, just doing fine again. And there have been a bunch of times, especially toward the end of my career, when there was more emphasis put on quality chest compressions and not ever stopping chest compressions, that I've gotten a pulse back on somebody who was in cardiac arrest. For the most part, we never hear what happens to those people. I don't know how many of them ended up surviving, how many of them ended up dying soon thereafter. I would guess most ended up dying soon thereafter, but I really don't know. Sometimes you see in the newspaper, on the news, some patient will come back to the fire station or hospital or ambulance service or whatever that took care of them when they had their emergency and saved their life, and they get their pictures taken together and it's this happy reunion. I never had that experience. So the vast majority of my ROSC, return of spontaneous circulation patients, I have no idea if they made it, didn't make it. I don't know. But that lady there is probably the one person I can really point to and say that person's in the world still because of something I did. And that's a very cool feeling. And there are lots of other times when people were in extremis from one thing or another, heart attacks, strokes, heart failure, when I'm sure that my actions, our actions, just in doing our normal thing and getting them to the hospital in a timely manner probably made a difference in their outcome. But it's not really the same as going from dead to alive. Working in the pediatric ICU as a nurse, I got to be involved in a lot more critical kinds of situations. In theory, a person doesn't make it to the ICU unless they're really sick. And that turned out not to always be true, but I would say the ratio of BS to truly sick is a lot more favorable when you're working in an ICU. And in a pediatric setting, mostly what you're dealing with is respiratory issues. We dealt with a lot of DKA, diabetic ketoacidosis. And it was very cool to be involved in those situations where you see a kid come in really not doing well, and then over the next few hours or days or however long it turns out to be, they get better and they gradually come off of all the things that we started, and then they go on out to the regular floor and then they go home. A lot of people in medicine don't really get a ton of experience or training in pediatrics. And so I think a lot of people are uneasy about caring for kids. I know that was true for me when I worked on the ambulance. My pediatric training as a paramedic student consisted of going to a pediatrician's office and following him around for a couple of days. People who are lucky enough to go to school where they can actually go into a pediatric hospital or a pediatric ER obviously are going to get a lot better training and that sort of stuff. But I had very little until I became a pediatric nurse. But one thing I learned is that kids are actually really resilient. It's kind of hard to kill little kids. We would get patients in the PICU who, had they been adults, you would take one look at them and go, oh, they're going to die. They're not going to get better. This is too bad. And kids just turn right around. I did have to do a couple of pediatric codes as a medic on the ambulance before I was a nurse. And those are probably some of the most stressful situations that you can be involved in as a first responder, because it's emotionally hard dealing with bad things happening to children. And like I said, a lot of people don't have a ton of pediatric training or experience. In theory, you know what to do. You have pediatric-sized equipment and protocols for dealing with pediatric patients, but it's just not what you do every day. And so you're already kind of nervous about the situation from that aspect, and it's just a lot of different things that play into pediatric calls being the worst. I guess my shining moment there would be a 4-year-old that I coded on the ambulance and got him back. He was a special needs kind of kid. I don't remember what was wrong with him specifically. I don't remember if he had a trach maybe or what the specifics were, but he coded at home and we were able to get his heart back going again and get him, I guess, relatively stabilized by the time we got to the ER. Felt really good about that one. After I left the PICU, the rest of my nursing career while I was working on my practitioner degree was in PACU, post-anesthesia care. And there's kind of this, I'm going to say, misconception about PACU. People kind of joke, oh, that's where nurses go to retire. That's the graveyard or whatever. Because I think the general impression is that you don't really have to do anything when you work at PACU. And there are some pretty freaking cool things about it. Like, you only really have 1 or 2 patients at the same time. And when you don't have a patient, you don't have a patient. You can hang out and read or stare at the wall or do whatever you want. If I was going to go back to working as an RN, I bet I would do PACU because it is a pretty sweet job. But it's more like an ICU than people would think, I think. Because you're getting these people who just came from surgery. They were just under general anesthesia. And so you have to be alert for any complications of the surgery. But more often than not, if you're going to have problems, it was because of the anesthesia. Because the anesthesiologists and CRNAs do a great job, but they don't always get it exactly right so that the patient is breathing on their own and not in pain by the time they come out of the operating room. And sometimes maybe that last dose of pain medicine, especially if you're talking about fentanyl, wouldn't have caused a problem except that you just put it on top of all the other stuff that they've had. And when somebody gets general anesthesia, they're getting a ton of medicine all at once. And so sometimes that little 25 or 50 micrograms of fentanyl will just make somebody stop breathing real quick. I probably learned more about airway management working in PACU than anywhere else, because there were many, many times when I'd have to start ventilating somebody, put in an OPA or an NPA, reposition their airway. And I know there have been many patients I've taken care of in PACU who, if I had not noticed that something was wrong with their surgical situation, or if I had not noticed their airway was compromised or they were not breathing and done something about it, their outcome would have been much worse. So yeah, shout out to PACU. There's a lot of real nursing that goes on there that maybe you wouldn't think. So anyway, nowadays I'm stuck in boring old family practice, and every once in a great while, somebody will come into us that really should have gone to the emergency room, and we get a chance to intervene in a more immediate kind of way. I saw a patient one time, I think just for a routine follow-up, and he mentioned that he was having some weird sensations in his chest and arms. And it was one of those situations where I was like, okay, I guess I better check his heart just to make sure, CYA more or less. And lo and behold, his troponin and pro-BNP were both elevated. So we called him and told him to go to the emergency room, and he got a stent like that day, I think. I had another patient one time that went to an emergency room complaining of abdominal pain. And this was not one of the big name hospitals around here. It was a very small, very outlying kind of place. And really, they blew her off. I think more or less they patted her on the head and told her she was constipated and sent her home. So she came to see me the next day or within the next couple of days. And she was sick. I mean, you could tell that she was not well. She was like the one patient that ever made it out of the ER without getting a CT scan. So we sent her for a CT, and lo and behold, she had crazy appendicitis. I want to say maybe it had actually already ruptured by the time we figured that out. But regardless, she was very sick and went and had emergency surgery and all that. I picked up on a couple little vascular things. One time I heard a carotid bruit in one of our patients and sent her for ultrasounds, and it turned out actually she had really critical subclavian stenosis. She had to get a big procedure to fix that. Another lady came in one time with a pretty much complete arterial occlusion in her leg. And I mean, you didn't have to be Dr. House to figure this one out. Like, her leg was blue and painful, and she was a heavy smoker, and like, you'd expect that. So she went and got that fixed. And so it's definitely neat to see those people going forward when they kind of give you credit for doing something that really helped them, save their life, whatever. But of course, mostly what I deal with now is just routine, day to day. Let's check your cholesterol and your sugar and see how your blood pressure's doing and What kind of concerns can I help try to deal with, which mostly come down to like joint pain, sleep issues, mood issues. But I'll tell you what, this has been really surprising to me working in primary care. I think it's actually more rewarding for me personally to establish these long term relationships with people and to just kind of see how they do over time and see how something that I offer or whatever helps their quality of life. I'm not restarting their heart, but getting somebody on the right antidepressant or getting somebody's blood sugar under control or making a diagnosis of something that they can get treated that improves their quality of life over time. That really makes a huge difference in people's lives. And obviously controlling those basic things, blood pressure, sugar, cholesterol, leads to better outcomes over time. So hopefully we're avoiding those situations where you need a paramedic or a ER or ICU nurse or doctor to come along and really save your life. And it's weird. You wouldn't think that that would compare to the satisfaction of knowing that you did something acute like that. But I think it's actually kind of better. And that's the thing I never thought that I would say, a conclusion that I never thought I would come to. If you had told 20-year-old me that I would end up working in primary care like this, I would have laughed in your face. It's not something I ever pictured myself doing. But you know what? It is kind of rewarding. So I guess the message here is whatever you're doing, whatever kind of medicine you're working in or interested in, focus on the good that you're doing for people. Because it's very easy to get bogged down in the day-to-day grind of feeling like you're not doing anything important at all. But you are. You're making a difference. You're helping people. If you are somebody who works out on the front lines and who's snatching people from the jaws of death, thank you for what you do. I know you don't hear that enough, even from the people you're saving. We appreciate you. We need you. We want you to be happy and well paid. But anybody else in any corner of medicine out there, the whole reason we go into this field is because we want to do good for people and help people. And you are. And thank you for what you do as well. I hope you hear that a lot from your patients and your supervisors and whoever. So that's what's on my mind this week. As always, thanks for listening. Special thanks to our Patreon supporters. Feel free to get in touch anytime, and I'll talk to you next time on Knowledgeable Provider. I would love to share your critical incident on the podcast. If you have a story you want to tell, send it to me by email at thekppod@gmail.com. That's thekppod@gmail.com. You can send it in writing and I'll read the story. You can make a high-quality recording of yourself telling the story and I'll play that. Or I can interview you about it, either remotely or in person. Thank you for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.